Good morning. Thank you for the opportunity to speak with you this morning about my project. I would like, in a show of hands, how many of you live in a rural area or practice in a rural area? And that would be, you could define that as in an area, a city of less than 10,000 people. So practice, okay. Okay. My project is in East Central Indiana, West Central Ohio. It is a rural area, 10 hours from here. And I chose this project because of my desire to work with COPD patients and improve their health outcomes. Okay, so this morning, briefly, I'm going to discuss the purpose of my project, describe to you the application of the vulnerable populations conceptual model, not sure if you've seen or worked with that before, and to depict my results in their application, as well as to demonstrate to you how you could apply this approach to improve COPD patient health outcomes. I will refer you to page 55 in our text. Look at it on your time, but it gives specifics about what I did with this project in terms of an abstract. And so I reference you to that. The other thing that I'm not going to do this morning is define and give you the pathophysiology of COPD. I hope that you'll have a little bit of background about that. But it does stand for chronic obstructive pulmonary disease, and it is primarily dealt with older adults, 50 and older. So, I don't know if my background is in adult health. I work at Indiana University East in their School of Nursing. I teach there. And so I don't know if you've worked with COPD patients before or in adult health, but what I can tell you is one of the reasons why I chose this project is because in 2015, COPD became a benchmark for 30-day readmissions, which means that if you have an individual in your facility who is readmitted within 30 days, the reimbursement is not going to happen. If they are diagnosed with the same diagnosis of COPD. Now, let me use my little wand here and show you my study hand. Right there is about where I live, right in that line. 1 minute I'm in Indiana, 1 minute I'm in Ohio. And if you look at this whole diagram here, this is a significant prevalent area for COPD, which is another reason why I chose this project. My desire in the end is to work on self-management programs in patients with COPD. And so starting, if any of you have worked on a process that involved a program of improving health outcomes, I began with an assessment, finding out really what the needs are of the population and what their perceived needs are. We can develop amazing programs, and if we are not fit with what the needs are to that area, it's kind of futile. Okay, so this project was developed using the vulnerable populations conceptual model. Any of you familiar with it? It's not extremely popular. Jacqueline Flaskert in 1998 sort of put the model together in dealing with vulnerable populations. Briefly, vulnerable populations would be elderly, rural patients, poor minority, children, mental health components. And so being rural and being elderly, we fall right in this category. One of my favorite things about this model, transparently, is that it's very easy to understand. There are 3 concepts: resource availability, relative risk, and health status. The premise is that communities are responsible for promoting health status in vulnerable populations through increasing their resource availability and reducing their relative risk. To break it down a little bit farther, resource availability, there are 2 types: socioeconomic, and environmental. Socioeconomic would be things like what my education level is, my marital status, what my income is. Environment would be what healthcare programs are available in my area, the quality of care, and those type of things. Relative risk would be defined as race, gender, lifestyle choices, my health habits, and so risks are modifiable and non-modifiable. And then health status would be things such as life expectancy, comorbidities of disease, what my mental status is, age-related differences, and thus. So the premise of this model is that resource availability and the number of resources that I have affects what my risk is, which in turn affects my health status, which is why I really like the simplicity of this model. But then my health status can tax my resources or affect my relative risk. Let me give you an example. If I am someone who has a lower education level, so I didn't graduate from high school, I live by myself, I'm unemployed, I live in a rural area, let's say I'm female, I'm white, I'm in my 20s, I smoke. Okay, so now do you see how my resources affect my risk? Then my life expectancy is less. I probably have comorbidities. I may or may not have mental stability, and that's kind of how that model works. Okay, so any of you have ever worked with surveys before? I got 70, and at that time, which was almost a year ago, that was gold to me to have individuals fill out a survey, 70 of them. And what I looked at, I created a survey that was 30 questions developed by the other valid surveys, I will say, CARS, which is Community Assessment Risk, HARP, which is one used in Canada, and both of those tools look at individuals and their risk for going in the hospital and their cost for their chronic diseases, as well as the COPD Quality Patient tool. Taking questions from those valid tools, I created my own survey to look at the vulnerable population's conceptual model of resources, risks, and health status. So I asked them their age, their education level, if they were married, whether they worked, what healthcare program availabilities they had, whether they felt like their COPD care was quality care, if they had transportation, some demographics, and then if they had comorbidities, how many medications they took, a little assessment of their mental status, COPD status, and if they felt like they were managing it, and then other things that affected their life expectancy. And here is what I found. So for resource availability in this population of East Central Indiana, West Central Ohio, their frequency were, higher frequencies were that they had education level of high school or higher. They lived with a caregiver and were married, and those were like greater than 85% of the people that were surveyed. And then on the lower end was the employment. Most were retired or unemployed. Environmental higher frequencies for resources were that they did have transportation, and again, that was about 93% had transportation. They did felt like they had a friend support system, and they felt like they got good COPD care management. On the flip side, on the lower end, they felt like there was a lack of health program options for them and their health. Looking at relative risk, obviously, one of the highest risks for their relative risk were that they were 65 years or older. Curiously, 33% still smoked, even though they had COPD. And then a third of them reported increased sadness with having COPD. About 12% reported that they needed more support from their COPD provider. In terms of health status, the highest frequencies were that they were able to complete activities of daily living, and this was about 2/3 of the surveyed individuals. Another high frequency was that they had 3 or more doctor visits in the past, and that they felt like they knew how to handle their shortness of breath. On the low end, they had 1 or more visits to the hospital in the past year. And if you're wondering, how did she get these frequencies? After the surveys were collected, we ran SPSS version 21 for descriptive statistics, tests, and chi-square. Okay, so now I've got this data, and what do I do with it? Things to consider in terms of the results were that they had a significant education level, in my perspective, from your typical rural population. There was someone in the home and a family support to help them. In terms of resources, they also had transportation and health promotion options. In terms of risk, there's 33%, and then a third, 33% were still smoking, and then a third felt like they had increased sadness. And what does that mean? So my mind begins reeling of probably screening every patient for every visit for smoking cessation. And what does increased sadness mean? Do we need to get a Beck index for depression and screen every patient every visit? In terms of health status, my results, the literature and what I found was that we needed to closely monitor the higher risk patients, meaning those who have had a visit to the hospital within 6 months, those who had 1 or more comorbidities with the COPD, and those individuals who were taking 5 or more medications. For this group that was surveyed, a couple of unique pieces. One that I alluded to, which is the second point, that there were health programs available through the hospital and pulmonary rehab, and why did they think that they didn't have them? The other piece that was unique, I felt like that came out in statistical significance, was that a majority of the individuals who lived in a more rural area stayed home and tried to manage their COPD and were more likely to stay home than those who lived closer to town. So how can I take all this information and now work toward my self-management program? And what am I going to do to apply it? So I'm in the process, and I've had some stakeholder meetings of, hey, we have these resources, they're educated, they're living with someone, they have transportation, they want to stay home. So talking to the stakeholders, which would be physicians and APNs and other disease navigators, case managers, working with them and having meetings on what now we can do with this that would work. Screenings in terms of, do we want to screen every patient every visit? What are we really looking for? And when we get the results of the screening, what are we going to do with it? What smoking cessation program are we going to promote? As well as applying this information to self-management programs. What will the insurance pay for? That kind of thing, which leads into my final bullet, which is further research. I need to figure out, so now we're primarily unemployed in terms of retirement, and how can we take this information and develop self-management programs that will effectively work to improve their quality of life and to promote their health outcomes. For those of you interested, in terms of rural health population, I would encourage you to look at the vulnerable populations health model and assess what the resources are, assess what the risks are, assess what the health status is of your area, and then work toward promoting your health outcomes as well. Any questions? Yes.
How did they say they took care of their shortness of breath?
Well, so to go into that a little bit further, the survey, that portion of the survey was Likert scale, right? 1 to 5, never, almost always. And the question was, I know how to handle shortness of breath when my COPD is exacerbated. That's my paraphrase, but essentially that's what the question is. So it didn't say how they handled their COPD, it just felt like they knew how to handle their COPD. So there is more research that needs teased out of that.
Yeah, because it seems like they really, that could be a potential strength, that they feel they have that individual ability to do that. But it also could be a hidden challenge, that they're not doing it well.
And that's a great point. And the other thing that I just have to be aware of is the people that were surveyed were the ones who came to the pulmonologist, came to the hospital. So they're already kind of engaged in their care. This isn't the ones who are staying at home that never show up. So, working toward that further. Although those are going to be the ones who are more likely to want to take care of their care and be involved in their healthcare program. Maybe I need to survey the caregivers who are at home, typically the females, who would want to help that individual who isn't interested in getting better initially, if that makes sense. So, I love rural health. Any other questions? Yes?
I'm just clicking in my brain. Do you even believe the model? Consider that in regards to disease severity and disease barriers and self-efficacy. Did you look at that model at all?
Human belief or health belief?
Yeah, I'm just curious whether or not you looked at that model in regards to that population.
I'm familiar with that. I didn't. That would be a great dovetail out of this, I think. But I didn't base my project on that. Okay, thank you.